Welcome to Dental XP. My name is George Romanos. I'm currently professor of clinical dentistry at the University of Rochester at the Eastman Dental Center, formerly clinical professor at the Department of Periodontology and Implant Dentistry at the NYU in New York. And for my former training, I'm fully periodontist. I trained periodontology in prosthodontics and in oral surgery in different various universities in Germany. The topic of my presentation today is the immediate functional occlusal loading in compromised and augmented sites. This is a very unique and controversial topic, immediate loading in general, especially immediate occlusal and functional loading. But the most important thing is we know that there are any publications, any scientific data in the current literature in the area of immediate loading in compromised and augmented sites, especially in the maxilla. We will focus now for the next 15 minutes in this issue. If we look a little bit more deep and seriously in the literature, internationally, immediate occlusal or functional loading is dependent on the presence or absence of occlusal contacts in the provisional restoration when we place implants and we restore the implants within the first same day or the first 3 to 4 days after surgery. This is actually based on the consensus conference in Barcelona in the year 2002, published by Apparition co-workers in clinical oral implant research in the year 2003. The main now question is, what happens if we have compromised sites and we want to augment also, and we want to use immediate occlusal loading concept? The first information we got regarding to the biological response of the alveolar bone using the monkey model, doing in vivo studies at the University of Malaya in Kuala Lumpur a couple of years ago. We decided to use an implant system which has a progressive thread design and also a platform switching and conical implant abutment connection, which is the Ankylos implant system from Freedom Dentsply. In this particular study, which I present you here and I'd like to share with you, we decided to make a comparative analysis on the biological response of the bone and the loading forces in the same monkey at the one side in the mandible, in the posterior part of the mandible, using delayed loading protocol, and in the contralateral side immediate loading protocol. Specifically, we found out in this publication, which we published in JOMI in the year 2002, that if we compare delay loaded implants, and you see here the left side of the screen, compared with the immediate loaded implants at the right side of the screen, that the bone actually reacts and can be remodeled in a very, very nice way, in a similar way between the two groups, exactly at the areas where we have loading forces. That means in the areas around the implants and also the surrounding adjacent periodontally healthy teeth in this model, we have always new bone formation compared to the far away areas of the mandible where the bone is very, very poor in the density. If we compare now these two implants in this group, or two group of implants actually, delayed and the intermediate loaded implants, with the progressive thread design and the implant abutment connection, which is a more stable design, we found actually many big differences between the two groups in the histomorphometrical level, and I will point it out this issue in a couple of minutes. I'd like to present you a couple of histological pictures which show a very unique characteristic of this, first of all, biological response of the bone, because as we know from orthopedics, everything which is splinted, immobilized after surgery, for example, if we immobilize fragmented bones when a patient has an accident, for example, and we make a surgery in the orthopedic department, we are able to immobilize with rigid osteoplating systems today and not anymore to cast fragmented bone, for example, TB of a patient. And using this immobilization, we are able actually to have a faster healing. On the other hand, the patient has to be able to load these immobilized previously fragmented bones. In a similar way, we have also in implant dentistry a similar reaction. I have to come back, excuse me here. A similar reaction of the bone around the surrounding bone around the implants, if we load these implants immediately, and if of course the implant design and the implant abutment connection has special characteristics in order to get a tissue care. Here, for example, specifically in these three pictures, I'd like to present you the alveolar bone on the top of the implants, which is stable, and in a higher magnification is a very unique characteristic that we have in implants which have been placed very close together in a less distance than 3 millimeters, because in the monkey model we don't have actually this opportunity to place implants in a far away or in a distance of more than 3 millimeters, that we have bone which is stable after 3 months of loading and healing period here in the immediate loading area over the platform of the implants. Even these implants, they had a smooth surface on the top of the platform and not any acid etched. Today, this specifically system exists with an acid etched surface on the platform. In addition to that, at the third picture, in a higher magnification, you realize something very unique, which is not actually dependent on this system and this connection, but also is a concept of treatment, because we didn't remove the abutments any time during the entire healing period and also loading period. You see that the bone is stable over the platform, and the most important characteristic for me as a periodontist at that time is that the epithelium does not migrate, doesn't go deeper, and doesn't create a potential pocket around the implants. If we go now a little bit deeper histomorphometrically, we found out that the bone-to-implant contact percentage is not different between immediately versus delayed load implants. We have approximately 60 to 65% bone-to-implant contacts, and if we compare now this percentage with the bone density, this is here in the terminology is bone area or bone volume or mineralized bone, we have around the immediate-loaded implants significantly much more bone compared, dense bone compared to the delayed loaded group of the implants in the same actually animals in the same part of the mandible. Let's go now to the clinical reality, and let's focus on the posterior mandible, which is very poor in the density. And we decided here to do a similar clinical study at that time in our patients, at that time at the University of Frankfurt in Germany, together with Hubertus Lentwig. And this is part of my PhD, published by Quintessence in the year 2005. You see that in the posterior part of the mandible we placed 3 implants. In the contralateral sides, this is the delayed loaded site, but we compare the 2 sides together, and you see here specifically that we do, in the last picture, immediate loading, functional loading. We have occlusal contacts, but of course we don't overload the implants, and we don't load the implants with high forces. In terms on this issue, we have to discuss a little bit more later on in the next cases also, that we don't advise to the patient to give a normal diet for the initial stages of the healing, especially for the first 4 to 6 weeks after the surgery. The patient has to use soft liquid diet. This concept actually on the posterior part of the mandible with only in this split mouth design with only one unilateral bridge or unilateral splinted crowns, it's much more dangerous actually, and it is more controversial and more complicated compared to the cross-arch stabilization, because we have bending moments and these can be very dangerous in order to, and we can have failures of the implants. But actually, in this publication, we found out that all of the implants were healed. We had 100% success rate. I don't talk about survival, talking about success rate. We measured all of the periodontal parameters in the soft tissue and in the hard tissue. And you see here that in this particular case, in the immediate loaded group compared to the delay loaded group, we didn't have any bone loss in all of the implants. This implant was independent from this study. It was not splitted with these posterior placed implants. Let's go now more and focus on the clinical outcome of immediate loaded implants placed in the maxillary arch with or without augmentations using cross-arch stabilization. And I'd like to present you actually a biological concept which is maybe controversial for some of you, and I believe, but I believe very strongly that we have sometimes to be controversial in order to prove new methods of treatment. In the first actually group of patients, they have been treated by myself and one or two different maybe dental technicians. I did a prospective actually study with 15 patients. Each patient was edentulous in the maxilla. 6 implants have been placed in the maxilla of these patients, and we used the Ankylos implant system by Freehand Dentsply. And we advised immediately after surgery to use soft liquid diet for the first 8 to 12 weeks. Specifically, what we did in these cases, we have a first group, immediate occlusal loading in augmented bone in compromised bone quality. In other words, I present you and share with you this clinical case with a very big actually defect at the left side of the maxilla, where we transferred bone from the posterior mandible, and then after 4 months after the healing period, we decided to place 6 Ankylos implants with this progressive thread design and to immobilize together these implants using a provisional restoration, having occlusal contacts with the lower jaw. I'd like to show you here in this particular case, in the second picture, that we have already occlusal contacts and the split, the immobilization, the splinting with the cross-arch stabilization. From the aesthetic standpoint, you see that the patient cannot complain at all. He has a very, very good clinical outcome and very aesthetic result. Even this is a normal temporization. And if you look a little bit more, the long-term data, which is my main focus on this presentation, the academic standpoint, to show and to share with you not only short-term experience, but experience after 2 years, after 4 years, after 5 years. Like in this particular case, we do not have any bone loss. I'd like to present you that here in this particular cases, we have with this particular system, with a subcrestal placement of 1 millimeter, for example, we have a stabilization of the bone level, and I do not believe anymore that we need to place the implants in a supracrestal or epicrestal level. Sometimes, in order to have stabilization and tissue care, we need to place the implants a little bit deeper in order to have stabilization of the soft and hard tissue. Certainly in this particular case, we could place more implants. We'd like to place the minimum number of implants here, 6 implants instead of 8 or 10 implants, and that's why you have these cantilever bridges. But we see also that even cantilever, distal cantilevers, they can work efficiently over a long period of time. The next case is immediate occlusal loading and simultaneous augmentations in the maxilla. As you see here in this particular case, I present you the left side. We had a limited bone in the width, 2.5 millimeter in the width, where we had to do bone spreading to spread the ridge in these particular areas of the osteotomy, not to split the ridge and to make the maxilla much more weak. And in addition to that, to augment with autogenous bone, which we collected from the residual, the parts of the residual ridge or from the tuberosity. The implants have been splinted together, have been immobilized with the temporization, and this is after 1 year the full arch reconstruction in the upper and also in the mandible was also immediate loading in this particular case. And you see that we have a very nice aesthetic result. The patient is very happy and also a good bone level. The same case, after actually 5 years shows also a good stable result. The restorations are not screw design restorations. Actually, I don't like and I don't need to have screw design restorations. This is another issue which we can of course discuss in another time with Dental XP, because actually screwdrivers and screws, they are not very easy to use in our days, and it is much better to use Bond or some other resin-based material for the fixation of the bridge. These patients, they come to the clinic once per year. We evaluate the stability of the implants, and also we evaluate the periodontal measurements in order to have scientific data.